When we look again, then we've looked at C5 as a level. We looked at then the aberrancy movements, but first the strengths. Strength in C6, strength in C7, okay, and strength in C8. Okay, each of those has a very specific level. T1 is the fingers spread, and then we can actually look at T2 with the upper pectorals. This is a quick way for us to assess, and the amazing thing is, as we've done this for now going on 10 years in September, we actually can out-predict the MRI. When we actually look at these levels of disc and we send them in for a confirmatory MRI, it will actually show up on the MRI for a disc problem. Okay, pretty neat. And this is this again is just it's a great work. It's exciting. What's the difference then between the disc and the arthritis? Arthritis pains are the joint pains that occur in between, and these are where we'll start to see then the loss of range of motion with what feels like a bony end feel. I try to push it further, but it stops. Okay? Try to push it further, but it stops. And when we look at that bony end feel, it locks, then we're actually going to have to look at the quality of that pain. Most arthritis, when we look at osteoarthritis, just like the hands and the knees, I wake up and it hurts worse, but once I get warmed up, it feels better. Okay? So my neck, every morning I wake up, my neck is so stiff. I get moving around, I have to do my little exercises or whatever it is that I do. And once I've been up for a couple hours, it starts to feel relieved. Okay? So that's more commonly the arthritis. That is not rheumatoid arthritis. Rheumatoid arthritis, because of its autoimmune inflammatory response, has more of the inflammation like the hands and the change in the joint shapes. And the worst of it is when inflammatory arthritis of rheumatoid actually eats this ligament, and when the person flexes their head forward, it actually drops because that ligament's gone. Okay? That's advanced degenerative rheumatoid arthritis. When we look at the other types of pain, the muscles, muscle injury, the most commonly missed, let's just say missed or misdiagnosed cause of post-car accident pain is the lack of fixation or correction of the jaw. Okay, let me say that a different way. When you've been in some type of an acceleration-deceleration injury called a whiplash, the most commonly missed joint that remains uncorrected for years is the jaw. This free-hanging sling, when your head gets thrusted forward and back, actually disrupts all the mechanoreceptors and actually creates an aberrancy in the face as if I've been punched, like a person getting knocked out, or can actually create then a change in feedback to the brain that creates with it a traumatic brain injury. So people who have been boxers, when you see they've hit these, they say, oh yeah, he's got this steel jaw, a square jaw, or this tough jaw, versus the guy that has the soft jaw or the glass jaw. They so often have with it the concussive injuries, but from having the aberrant feedback through their jaw because being hit, it creates a traumatic brain injury because of the loss of feedback. When we look at people who've been in car accidents, when we're treating people who've been in car accidents, if you've been in a car accident, make sure that your jaw is appropriately assessed and appropriately corrected. Okay? What do I mean by that? Simply sticking a bite guard in your mouth will not correct that. It's not just a simple, yeah, I got a football mouth guard, yeah, my teeth are matching. Okay? It has to do with all of the neuromechanoreceptors that feed back to brain that are now aberrantly firing, so that when you close your mouth, your teeth actually find home. Okay? Does that make sense? If you've had a car accident and your jaw has not been corrected or evaluated, make sure you have your jaw evaluated and corrected. And the first piece of the correction should be in the small jaw, a tiny bone underneath your jaw itself called the hyoid bone. Okay? There's a tiny jaw underneath, if you will, called the hyoid. It's spelled Hyoid, and you have to have the hyoid bone checked and corrected to restore occlusion for the bite. Okay? How many of you have ever been to a dentist, been laid back in a chair, your jaw drops back, and you've had a procedure done, and then the dentist says, how do your teeth feel? And you're clicking your teeth together after your jaw's been open for 2 to 3 hours. And you sit up and your whole mouth feels, I can't feel anything on this side, not doing on this side. And he understands what you mean, right? If we really want to see a change in the aberrancy, for those dentists who are watching this, to restore, if you've had a patient lying back in a chair, bring them all the way up to sitting first, have them slide the jaw forward, then open wide. Okay? You have to recode the jaw. In other words, you're going to slide, oh, thank you for being a volunteer. You're going to slide the jaw forward, open all the way, and then bring the teeth back together. Okay? Slide the jaw forward, open all the way, and then bring the teeth together in normal occlusion. Okay? Because what happens when you're lying on your back with your mouth wide open is your jaw starts to become inflamed, and this temporomandibular joint, the longer you're in that position, creates stress on the disc that's in the temporomandibular joint, and that disc actually starts to swell, such that when you try to close your jaw now, you will have a change in your occlusion, meaning the way your teeth contact. They'll come back in an aberrancy. Okay? So the first thing that you should do is sit up, slide the jaw forward, open, and close in normal occlusion. Slide the jaw forward, open, and close in normal occlusion 4 times. Then have the patient come all the way to standing upright, slide the jaw forward, open all the way, and come back to occlusion. And now tap the teeth and see how does it feel. Okay? When they're coming back in for their follow-up, oh, this tooth, it just hasn't felt right since you put that cavity in, filling it for me. Or this tooth, you know, all we did is a cleaning, but ever since that cleaning, we were doing that scraping, it just hasn't felt right since then. Recode their code by doing that movement first, and then have them standing when they're on their follow-up. Then we'll set them down, have them tap their teeth first and check it there, then tap their teeth when they're sitting, and then tap their teeth lying on their follow-up. You'll get a more accurate sound to your occlusion.
So how do you get a dentist to do that? Just tell him, hey, I don't want you to...
Have them watch our video. Actually, we did try to do a study club one time, but if they're unsure of what to do, or you're not quite sure how to, there's a dentist on the back row. You can visit with him. He can talk to you. Okay? This is what we look for, though, is appropriate occlusion. And when we see that temporomandibular joint disrupted and the change in the feedback from it, again, if my head is tipped to one side, this is exaggerated, of course. If my head is tipped to one side, this jaw will just hang. Okay? So my body, in its attempt to right, will bring the eyes corrected, but now the jaw is in a crossbite. See that? Okay? Again, if you've been, though, in an acceleration-deceleration injury, if your jaw has not been checked after a whiplash injury, have it assessed and corrected. Okay? Everybody good there?
Did you do that?
Yes.
You do that.
We do that. No. This is where we want to work with a dentist. If you've had that, what I'm saying is come and see a person who's done a lot of research in neurology, okay?
I usually have to have them come back when
Correct. That's exactly right. That's what I'm saying on the follow-up.
Yeah.
Have them come in, have them decode that jaw, and send them home with that first, and then when they come back, decode it again, and then when you adjust the bite, have them come all the way to standing again, then Okay, go through that whole motion again and then correct the aberrancy from there. Okay, great. Any other questions there? Finally, we'll talk about muscles just for tonight. Okay, trigger points in the muscles actually will refer back into the face and head in the sternocleidomastoid, the scalene muscles, the trapezius muscles, which actually will refer all the way up to the back of the head and into the eye. Okay, so those are all trigger points. Those are the ones where your spouse presses in your shoulder and it's that Vulcan death grip. They don't even know how to do this. It's like, how did you do that? You're killing me. Okay, remember, muscles have to be corrected as well. If there's an infection, correct the infection. Find it, fix it, and get on with life. Okay? We talked about then corrections. We saw tonight a correction for a disc. This type of a movement, we've actually seen people, specifically dentists, who were going to quit practice because they were dropping their tools. Come to us, do this range of motion, come back and see us a year later and say, big hug, thank you, I'm still practicing dentistry because my discs are corrected. Okay? Just by doing that simple exercise. If we have advanced arthritis, we need to correct what we can within the limits of the arthritis and maintain and optimize the range of motion to get rid of, first of all, the disc referred pain, and then the bony stops if we can. So in our office we actually use an instrument with a head that's been moved through a full range of motion rather than just a single snapshot to correct. Okay? The last things then, again, when we talk about correction, we've talked about the jaw, we talked about the range of motion of the jaw and decoding it, also the hyoid bone, and then when we look at the musculature, if you have a disc problem, do not hold and stretch the disc when you're correcting the muscles. Because if the disc is being protected by the muscle and you push the head into a sustained posture, just like the disc of the jaw, a sustained posture can actually push that disc into a further demise. Okay? So we like to use range of motion and movement, and even movement for when we're working on muscles, rather than working them in a static hold and stretch posture. Okay? So especially in your case, Carolyn, when we're working with you, we will not just hold you and try to push something very forcefully. We'll actually move it in its range of motion. Okay?
Yeah, because I've been pushed.
Correct, and it
Yeah.
won't make the difference.
Okay.
Okay? That's us for